Isoprenaline or isoproterenol. Isoprenaline is essentially a pure beta stimulator with virtually no effect on alpha receptors. The ECG that needed a drug, not a pacemaker. A 68-year-old man arrives in the emergency department after suddenly collapsing. His pulse is only 28 beats per minute. His blood pressure is falling. The ECG shows complete heart block. The emergency physician calls for an emergency pacemaker, but it will take another 15 minutes to prepare. An IV infusion of isoprenaline is started. Within minutes, his heart rate rises, cardiac output improves, and his blood pressure stabilizes. How can one drug rapidly increase the heart rate and cardiac output in such a critical emergency? The answer lies in isoprenaline, a non-selective beta-adrenergic agonist that powerfully stimulates both beta-1 and beta-2 receptors, making it essentially a pure beta stimulator with virtually no alpha receptor activity. Mechanism of action. First, at beta-1 receptors in the heart, it increases heart rate and contractility, which leads to an increase in cardiac output. Second, at beta-2 receptors in smooth muscle, particularly in the bronchi and blood vessels, it produces bronchodilation and vasodilation. Vasodilation lowers peripheral resistance, causing a fall in diastolic blood pressure. Therefore, the net effect is increased cardiac output with decreased diastolic blood pressure and peripheral vascular resistance. Clinical uses. First, it is used in bradycardia and heart block as a temporary measure when pacing is unavailable. By stimulating beta-1 receptors, it increases the heart rate and helps maintain cardiac output until a pacemaker can be inserted. Another important use is in Torsades de Pointes, where increasing the heart rate acts like overdrive pacing to suppress this life-threatening ventricular arrhythmia. Isoprenaline may also be used in beta blocker overdose because it overcomes competitive beta receptor blockade, restoring heart rate and myocardial contractility. Finally, it was once used in bronchial asthma because of its bronchodilator effect through beta-2 receptor stimulation. However, it has been largely replaced by selective beta-2 agonists like salbutamol. Adverse effects. We can classify them into cardiac, vascular, and other adverse effects. The most important are the cardiac adverse effects. By strongly stimulating beta-1 receptors, isoprenaline can produce tachycardia, palpitations, and even arrhythmias. It also increases myocardial oxygen demand, so in patients with coronary artery disease, it may precipitate angina or worsen existing ischemia. The principal vascular adverse effect is hypotension due to vasodilation. This occurs because stimulation of beta-2 receptors in vascular smooth muscle reduces peripheral vascular resistance, leading to a fall in blood pressure, especially the diastolic pressure. Among the other adverse effects, patients may experience headache and flushing, both of which are related to peripheral vasodilation. Key takeaways. First, remember that it is a pure beta agonist. It stimulates both beta-1 and beta-2 receptors with no alpha activity, making it the prototypical non-selective beta-adrenergic agonist. Second, it is primarily a cardiac emergency drug. It serves as a first-line temporizing agent in heart block, Torsades de Pointes, and beta blocker overdose, especially when definitive treatment such as pacing is not immediately available. Finally, although isoprenaline is an effective bronchodilator, it has been largely superseded in asthma because selective beta-2 agonists such as salbutamol, provide bronchodilation with far fewer cardiac adverse effects.